You have water
We're going to be talking
soluble
about gallbladder
bilirubin.
problems, right? Mainly cholelithiasis, gallstones. Um, to understand the problems, the symptoms
You have
that we
water
have with
soluble
gallstones,
bilirubin
you have to
because
understand what the gallbladder does. So, bile, that's pretty much the sum total of what gallbladder does, is it holds on to bile. It doesn't make it, liver makes it, and as the liver makes it, it goes down through the hepatic duct, through the cystic duct, and uh, stores it in the bile, and the gallbladder holds on to it and absorbs the water out of it through the walls, and by doing that, uh, it concentrates it, makes it a little stronger, right? Pulls some of the water out, it's less dilute, more of a concentrated solution you end up with after it's sat in the gallbladder for a little while. So if you look here, the liver makes the gallbladder, or makes the bile. Person eats some food, right? Comes down here, gets churned up in the stomach. Stomach says, hey, we got some fatty food in here, right? Let's say you ate a brat or something, something's got a lot of fat in it. So it sends through cholecystokinin, which is a hormone, it sends that out, and it goes over to the gallbladder and pancreas and tells them, get busy, we got some fat coming in, right? So then the gallbladder says, all right, and it squirts some of the bile out of it, right? So the person ate, food's in here, and now if you look, then the food is going to get pushed down into the duodenum and go through the, and right here is the common bile duct, which has your enzymes, has your bile coming from the gallbladder, and right, bile from the gallbladder. This is the gallbladder, and your digestive enzymes from the pancreas all will come through there. That's this little guy here, right? So it's coming through here. So I've already talked that over here, you got the fatty food in there, releases cholecystokinin. It comes over here, it tells your gallbladder, squirt some of that in there, tells your pancreas we got some fat coming through, squirt some stuff down in there, right? And all this digestive juices. So then we got to take a look at something here. The liver is where the bile is made. And the liver can get rid of things in that bile too. If it's got stuff that it doesn't really particularly like, it can sometimes add it to the bile, because it's going to come down here into the digestive system and then right out the other end, right? So it gives you a chance to get rid of some stuff too. Some of the things that we get rid of, we'll always say, X amount of it, usually a high percentage of it, is going out through the kidneys. Some of it, though, gets taken out by the liver, thrown down here, and you get rid of it. So anyway, the liver is constantly making this bile, and it comes down here. You've got a sphincter there that it will kind of leak through and let it go, but it holds just the bile in here, in this whole duct, and in the gallbladder. Whatever gets backed up in the gallbladder is a little bit stronger, right? It's a little more concentrated, like I was just explaining, because it absorbs the water out of the bile. So now this over here, the food was in there, it released the cholecystokinin, comes over here, gallbladder squirts. So now you've got, in addition to the little bit of bile that comes down into the duodenum anyway, you've got an extra amount, so a little more quantity, and I guess you would call it a higher quality as well, because it's going to be more concentrated. So when that fat comes down there, boom, that bile can work on it. And you said, what does the bile do? Well, what the bile does is it takes the globules of fat and breaks them up, right? So let's say this guy just ate that and it came down in here and you got these big globules, right? These big globules of fat. Big old globules like that. Well, after the bile comes down there and starts and gets mixed in with it, it turns these big globules into little droplets all over, right? Right? It's kind of like if I took on my desk and I just put a big glob of fat on there, and then I came along with my hand and I just spread it all out. That's what you're doing. You're spreading it out. So that's what we did here. We had the big globules and we spread it out. And now, being released from the pancreas, you have one of the enzymes being released there is lipase, right? So lipase comes down here, and now it can get to more fat, right? It can get to all this fat and break it down into free fatty acids, which is something that we can absorb. We couldn't absorb it otherwise. Now, if you go back and look at the way it was, and you have this big globule, right? Now, let's say you have some, we'll make it blue. Lipase is blue today. So it comes in here and it can get around the outside of that and break down the outside of that. Okay, well, it's missing all of that inside there though. But when you have those little droplets all over the place, right? Let's say it's just spread out like this. I'm just doing it like that because it's easier. And now it can get to all this, right? It's getting to almost all of it. Especially if you have the little droplets like I drew before. Just didn't want to have to draw the blue around each one of them little droplets. So anyway, it can get to more of that fat, and it can break down more of that fat. And so then now when it goes through, you can absorb the fat. And believe it or not, it is very important to absorb fat. It does have calories. It's got some importance there. But another very important thing about fat is you need it to absorb your fat-soluble vitamins. Right? So if you want to absorb your vitamin K, vitamin D, A, and E, you need to be able to absorb fat to get that absorbed into your system. So what happens when you get gallstones? You know, what's the problem there with gallstones? Let's draw some gallstones in here, and I'll make them green, right? So you got some stones here. Right? This guy's got some stones there in his gallbladder. A lot of people are asymptomatic. Many people are just asymptomatic. They have gallstones in there, and they just don't end up getting the symptoms. They're lucky enough that it doesn't get stuck. But for the people who do get the symptoms, when are they going to get symptoms? Right? Well, when a person eats something and you get the fat in here, right? They eat some fatty foods. It releases cholecystokinin. It tells the gallbladder to contract. What's going to happen to those stones? They're just kind of sitting in there now. That gallbladder contracts, right? And it pushes them up, right? This guy just pushes this bile up through there. Well, these stones now, one of them can come here and it can shove it right into there and it can get stuck in there. Right? I just drew your little stone got stuck in there. Well, now, with that stone stuck in there, the gallbladder's pushing on it and you get a stretch and you can end up with inflammation, or you can end up with just the colicky pain. So this person's going to say, after I eat, sometimes I just get this horrible pain. Pain is usually in the right upper quadrant. And then you can say, do you notice what you eat? And a lot of times it will be after they eat fatty foods, right? Something fried or something that's got fat in it, because that is when the gallbladder is really stimulated to contract. And that's what's going to push one of these little stones in there. And then after the gallbladder relaxes, and it might take a couple hours, might 2 to 4 hours, gallbladder relaxes, and then this stone here might fall back down in there. And then they'll call that colic, biliary colic, they'll call that. And the reason they call it biliary colic is because there's not necessarily inflammation. It hasn't been there long enough to cause inflammation and all of those other symptoms. So when you have that, you just got this pain. It'll come and hit you pretty hard and kind of drop you to your knees there for an hour or two after you ate something, and then it kind of lets up. And by the way, whenever we're talking about colic, we're talking about some kind of tubular pain where you get like a torsion or twisting of that tube, or in a stretching or something, and that's what colic means. So you know, a lot of times people think of colic with their babies. Well, that's because they have a problem in their intestinal problem. Usually we'll hit them in the evening, and there's no other reason to see what it is, and so they say it's colic pain. Something with their intestines, and that usually they'll outgrow that. And like I said, of course, it's going to be exacerbated by eating fatty foods. Now you can end up with cholecystitis. Well, now you got itis in the word, right? So now you know that there's an inflammatory process going on. So it's inflammation. And usually what happens there is when it pushes it into that good enough that that sucker doesn't fall back down in there. So it stays there. And so they got constant irritation right there, and the gallbladder ends up being inflamed. And so they kind of have a pain that probably doesn't really go away. But when they eat something fat, it gets really bad. And now you got to think there's inflammation involved. So what goes along with inflammation? Um, Fever, high white count, right? So you'll probably find tenderness in the right upper quadrant, positive Murphy's sign. You're going to find fever and high white count. When I say positive Murphy's sign, what that is pain in the, that's my left, the right upper quadrant, right in here. And what you do is you have them take a deep breath, because when you have them take a deep breath, their diaphragm here pulls down, so it can pull the air down into your lungs, right? The diaphragm pulls down. When the diaphragm pulls down here, it pushes that gallbladder down. The gallbladder is under the ribs here, so you can't really assess for the tenderness of the gallbladder, because you can't push on it. It's being protected by these ribs. So you have them take that deep breath in, pushes the gallbladder down. Now you can get to it and you can evaluate for tenderness. So before, it might have been hard to press on the gallbladder and to initiate a response indicating the tenderness. But when they take that deep breath and it pushes it down, you can reach it there and ouch, ouch. They say, yikes, that hurt, right? In fact, you can put your hand under there and tell them to take a deep breath, and they'll stop on that breath as soon as that, because it starts hurting that gallbladder. So let's kind of write these down, right? I talked about biliary colic, B-I-L-I-A-R-Y, colic, C-O-L-I-C, or is there two L's in colic? I don't know. But I think there is. Should be phonetically. Who cares? And then the other one is that we talked about is cholecystitis, C-H-O-L-E-C-Y-S-T-I-T-I-S, cholecystitis. And so that means that this guy here is stuck in there and you're getting inflammation in the gallbladder now, right? And so now, let's say this guy gets pushed all the way down to here. I'm going to fill that in so you can see it well. Right? So now the stone is down here. That's going to add a new wrinkle to it, to our story here. So now what happens is the liver, before, when it was up here, the liver could release that bile, and it could actually get down here. The gallbladder would push, it would push against it, it would hurt like crazy, but this sphincter opens up and the less concentrated, but bile nonetheless, can still enter the duodenum. So the pain and all that was still a problem, but now it's down here. So what's going to happen with it down here? No bile can get down there, right? And things back up in the liver. So now when you have stuff backing up in the liver, you're going to have problems with liver. So now you're going to find elevated liver enzymes, right? So the liver enzymes are elevated because none of them are coming down and out. So they're all backing up. The liver is getting stimulated to make more of their enzymes. And your bilirubin, right? You're going to do liver function tests and you're going to find out that their bilirubin is elevated. And you got to remember where bilirubin comes from. You got a red blood cell. It breaks down, one of the products of a red blood cell breaking down. And remember, red blood cells only live 120 days. So you constantly, every day you have red blood cells breaking down. And every day you're making new red blood cells. And one of the things that red blood cells does is we recycle most of the stuff that it has. But what it does with the bile, or the bilirubin, they call it's unconjugated or indirect bilirubin, is what you get originally out in the blood. It has to come to the liver, and then the liver will conjugate it. It adds something to it and makes it water soluble. Before it's conjugated, out in the system, it is not water soluble. It's fat soluble, so the kidneys can't get rid of it. So the liver has to get it, and it will it will make it water soluble, and then it adds it to the bile, and it comes down here. And bile ends up making your poop brown, and then some of it gets reabsorbed here, and they're called different things. We don't need to know all that, but it gets reabsorbed into your system, and the kidneys will get rid of it, and that makes your pee yellow, right? So the bright yellow urine comes from the bile, and so does the brown poop, right? So as it comes through here, and it takes your from the system, it takes your right. So from the system, it gets this bilirubin, the product of dying red blood cells, and it will conjugate it and add it to the bile, right? And then the bile will take it, and it ends up making your poop brown and your pee yellow. So what's going to happen to a person when they have this? The conjugated bilirubin is going to back up into the blood, right? So now think about it. Conjugated bilirubin, normally there's not usually that much in the blood. It's usually the unconjugated, right, before the liver gets to it. Once it gets to the liver conjugates and gets rid of it. But now it can't, but now it's not able to get rid of it. So now in your blood, you will have a higher percentage of conjugated bilirubin, and that's called direct bilirubin. So so they'll always do it direct and indirect bilirubin, and they'll look at those two. And if you have a high percentage, over 50% of your bilirubin is the direct kind, right? The conjugated kind, the kind that the liver has already worked on, then that's way higher than normal. And they say, okay, the liver is not able to get rid of it. There's an obstructive problem with the liver, right? Because of this high level of direct bilirubin being out in the system. I hope I explained that well. So it's going to do a couple of things here, right? The bile is not getting down into the duodenum, and I said that's what makes your poop brown. Poop is going to be discolored, right? It's going to be really a light color. It's not going to be brown. Now, when you look in test questions, and I'm sorry, I don't write every test question that you're going to see, and definitely when you go to HESI or when you go to NCLEX, I'm not writing those questions, obviously. But when they call it an odd color, they might call it tan. Now, I had a student one time, because I had a question that said tan. She said, well, tan is what color poop always is. It's what color your BM should always be. So, and I said, yeah, but they were asking this question. The other three were not good answers. And by saying tan, you can figure that the test writer meant lighter than usual, because we usually call our stools brown, right? So the fact that they were saying it was tan should have been a clue that that was what the test writer was looking for. I personally like to say a light clay color, right? Just to get away from the wording that a student might think of. But every test writer isn't going to do that. Use your common sense. Just like anything when we're talking about nursing questions, use your common sense. So the bile does not get down through here, so it's not making your poop brown, so you're going to have a light colored poop, right? So this is the guy. And what I'm talking about here, I should write it down here, is called cholangitis. It's down in here. Cholangitis. And that actually is inflammation in the bile duct, right? That is very dangerous, because it's inflammation and infection, and even if not, inflammation can do a lot of damage. It can lead to liver failure, can lead to pancreatitis, right? Because it's right here. You can end up with inflammation in your pancreas, and then your pancreas can start auto-digesting, which is, of course, a really bad thing. And peritonitis. You can end up with peritonitis. And the peritoneal cavity is the entire cavity in your belly, right? Below your diaphragm, above your hips, right? That cavity. You can get inflammation and infection in there, which is very dangerous because it leads to sepsis and leads to shock. And shock kills. Now also think about your urine. Now all of a sudden, you've got water-soluble urine. It hasn't come down through and gone through the changes that it goes through in your intestines, which actually will add this urochrome to it, which is what makes your um, urine so yellow. But now it's coming back out here, and you get a whole bunch of this conjugated bilirubin in your system, right? It's more than 50%. You got a lot of conjugated bilirubin. So the liver has made it water soluble, and now it's out in the blood. The urine, the kidney can pee that out, right? It can filter that out because it's a water soluble thing now. So you end up with a lot of conjugated bilirubin in your urine. And by having a lot of that, your urine ends up a really dark color. And if you shake it up, it'll foam. Kind of a neat little side thing to tell you. But anyway, that's what happens there. We end up with real light colored stools and really dark brownish colored urine. Now, classic symptoms of a gallbladder problem: right upper quadrant pain, like I said, Murphy's sign. And the pain very often will radiate up into your right shoulder, or will radiate around. And this is how the patient says it. It hurts right here and it goes around to my back. That's how they feel it, like it's going around to their back. That's, I think, every time I've heard a gallbladder person describe their pain and when it's going into their back, that's how they say it. Whereas if they have a problem with their pancreas, usually they'll say it hurts here and straight through to my back, right? Kind of a little difference in the way they describe it. But also in the right shoulder, right? So you get this referred pain when you have problems in the gallbladder. Let's see. You'll do a CBC because you're going to look for that white count, right? It's going to let you know you got a lot of inflammation or infection going on there along with this gallbladder problem. You're going to look at their amylase and lipase, right? Amylase and lipase are enzymes, and they will be elevated from all this irritation, right? They will be releasing a lot. And you're going to check their bilirubin to see if it's high, if it's elevated, and to see if their direct ends up being higher than their indirect. And you're going to look at their electrolytes, right? Especially if they've been nauseous and vomiting, you can expect to have a change in their electrolytes there. And another thing is, if you're not getting bile down in here, you might not be absorbing your fat very well. If you're not absorbing your fat, you're not absorbing your fat vitamins. So vitamin K, they can end up with a hemorrhage problem because vitamin K is important for clotting. And if they're not absorbing vitamin D, which is a fat-soluble vitamin, that means they're not absorbing calcium, right? So if they're not absorbing calcium, you want to check and see what their calcium level is, because what happens if they're not absorbing calcium? Well, they can get bone wasting and then get tetany, right? Rigid muscles, right? They have a really hard time using their muscles or without their muscles jumping and things like that, and a lot of rigidity in their muscles because they've lost the calcium, which is the membrane stabilizer, right? And their bilirubin, right? So we know that if you have over 50% of your bilirubin is the direct or conjugated type, that it's a sign of an obstruction. Also, you will find the bilirubin in the urine. So they can do a urine test and look for bilirubin in there because there is direct or conjugated in the blood, so now it can be eliminated in the urine. Abdominal x-rays. Now you may be able to see the stone on there. I've seen the little shadows of the stone in the gallbladders, but usually you can't see that on just a regular x-ray. An ultrasound is a great test for looking for stones in the gallbladder. Right? They will go ahead and do the ultrasound, and ultrasound is sound waves, and they use sound waves to detect the stones in the ducts or in the gallbladder. Now, a lot of times when the stone is down here where this guy is, or now another thing that I didn't say is we can get way down here and then you end up with pancreatitis because it's blocking your pancreatic enzymes from coming down too. One of the big reasons for pancreatitis, one of the leading causes of pancreatitis is gallstones. Now, they can be either gallstone down in here, sludge down here, or just the inflammation in the area causing the pancreas to end up being inflamed also. But now I want to talk about a HIDA scan, because stones down here are very often missed on a gallbladder ultrasound. So they do this ultrasound, and it's really good at seeing them in here and usually in the cystic duct, but when it gets down in here, it doesn't see it very well. And they can do a HIDA scan. In a HIDA scan, they will use some contrast dye in an IV. They'll give it to intravenously, and it ends up going into the liver circulation. And the liver takes it and puts it in these ducts. Like I was saying before, it kind of gets rid of stuff. And so it takes these little pieces of dye that light up under X-ray, and it will push it down into here. Right, so then you got it in here. Now you can get an X-ray on there, and it will be lit up. And now they can watch for movement of this, right? Because you can see it in here. And what they do is they administer in the IV cholecystokinin. And if you remember right, I said that was the hormone released by the stomach to cause the gallbladder to contract. But we put some in the IV, and it will make this gallbladder contract. And now we can look and see, is it contracting here? And is this stuff, you know, stopping here, or is it coming down, stopping here? But by doing that, you're just pushing this stuff that's been added to this stuff with radiolucent dye in it, or contrast in it, so it makes it glow. And they watch it on a fluoral, and a fluoral is where you can see things moving, and you watch it on a little TV screen, right? So you got that little TV screen there, and you can hit this beam with the continuous X-ray, and then you can actually watch it, so you can actually see the stuff lit up coming here and going down, and you'll see it spreading out in the duodenum if it can. If it doesn't get there, then you know that you have an obstruction, and with this stuff you can see exactly where the obstruction is. But that's a HIDA scan. Very important test when it comes to gallbladder evaluation. So in the HIDA scan, they will stick an IV in, and they will give this contrast dye. It will end up in the hepatic circulation in here, and the liver will add it to the bile, get rid of it in the bile, right? So it's going to add it to it, and it's good. So now this contrast dye filled bile is going to end up filling the gallbladder. They'll give cholecystokinin. It will cause the gallbladder to contract, and it will push that down through there. And you can watch this on fluoroscopy. You can watch this all happening and see it moving. They can do an ERCP, right? ERCP, they put a person under conscious sedation. They take a scope down through their mouth, all the way down in here, right? And whenever you put a scope in their mouth, right, you're going to have to really sedate this person, and you're going to give them some Versed so they don't remember the procedure, and you put a bite block in there, right? You don't just put it in there. They're going to bite down on that scope. And then you stick the scope through the hole in the bite block. And then that goes down here, all the way down here. And then when they get the scope to the end here, they take a little wire and pass it through the scope, and it comes out and it cannulates the bile duct, and it cannulates up through here. And then they can squirt some dye in there, and they can see where there is any obstruction, and they can fix it too, because they will push a thin wire up past that stone, blow up the balloon, and then pull it back, and they'll pull that stone right out. So that's one of the things that they can do is an ERCP. A cholecystectomy, surgical removal of the gallbladder. A few incisions are made when they do that, and I don't know where they put them all, like one in here, one down here. But anyway, they got like 3 or 4 incisions, and each one of those incisions has a reason for being there. One of them, they can go in there and they'll inject CO2, right, to kind of blow the belly up so they can look around in there, because otherwise there's not really any room. And then they can go in with another one, and they got a camera and a light that will enable them to see what they're doing. And then the other one, I think they work through, right? The instruments will go through in there, and they can come in and they can clip this off and then pull it out through one of the holes. So that's kind of what they do. Like I said, I'm not a surgeon. Didn't work in OR, so I've never watched them. Well, I shouldn't say that. I have watched a couple of them done, just because I happen to be in the right place at the right time. And they can do an open where they cut it up the old-fashioned way and take it out. Sometimes that's just indicated. That is done much quicker in the OR, but the recovery time is longer because they have um, an open cut, I mean, this big cut there instead of just a few little ones. But as far as the scope goes, there's a lot of recovery. The recovery is just pain because they have that CO2 pumped into their belly, and it takes a while for the system to absorb that and get rid of it. So as far as treatment goes, they're going to be NPO at first, right? You're going to keep them in NPO because you don't want to be stimulating that gallbladder. Then you're going to advance that as they can tolerate it, right? Full liquids, clear liquids, low-fat diet always until that gallbladder is gone. And then they're going to advance it slowly because everybody will be able to tolerate a fatty diet in a different way. Some people say, I eat everything I always ate before and don't even notice any difference. Some people say, oh God, I used to love to eat brats, can't eat them anymore, right? And I always bring up brats because I remember a particular person telling me that. But so, if you think about it, the liver's making this bile, and it comes down here anyway, right? They're not getting the extra concentrated bile from the gallbladder, and they're not getting that extra squirt in there every time you eat something fat, but you do have some bile down there. So it kind of depends on the person how well they're going to tolerate fat after having the gallbladder removed, but it seems most people do really well. Of course, you have to manage their pain and their nausea and vomiting. Anybody with gallbladder problem is going to have a lot of pain and a lot of nausea and vomiting, right? So you can probably give morphine for the pain, probably give like Zofran for the nausea and vomiting. Real common one is IV antibiotics. You might give them IV antibiotics to prevent an infection, and if they had the surgery, they'll give them IV antibiotics because we always give IV antibiotics after surgeries because we don't want them getting an infection after the surgery. You've just opened them up, right? After a surgery, a lot of times they'll come in with a drain, and in that drain you're going to be having to empty it, right, and take care of the drain problem. There's some wording that you got to be aware of and what it means, right? Serous drainage means that it's a straw colored, right? It's just kind of a clear straw colored, yellow colored looking thing. So, and when I say clear, what that means is it doesn't have particles in it. Medical, when you hear clear, that means it doesn't have little fragments in it. It's just clear. It doesn't mean that it's clear that it doesn't have color, right? So this is a clear yellow fluid, a serous fluid. Now sanguineous means that there's red blood in it, right? It means that there's blood in it. So that means that there's damaged vessels. The person is bleeding from a traumatic damage to something. Serosanguinous means that there's a mixture, right? You got serous fluid in there, and so it'd be kind of a pink color, and some of the sanguineous fluid, right? The serous and the sanguineous, so it's serosanguinous. You can expect after a surgery and they have a drain, you can expect some serosanguinous fluid to be in there. That's normal. Pale yellow, the serous fluid is good, but the serosanguinous is normal. It can be expected. Sanguineous, you might kind of wonder, why is it bleeding out through here? Another word to be aware of is purulent. P-U-R-U-L-E-N-T. I have a hard time saying purulent. But anyway, and that just means pussy. It's full of pus, right? And you don't use the word pussy because I think pussy isn't actually a word, and if you want to spell pussy, it doesn't look very good on a chart. But you know that when you have a purulent drainage, it can be yellow, gray, or green, right? Any of the colors that you see pus, whenever you see pus anywhere. So that's a real quick story on gallbladder. I'll probably do some slides. It'd be a good idea to do some slides and do some reading on that.